Do you have a high risk for breast cancer? Do you know the crucial steps that could save your life? Breast cancer risk isn't just a statistic, it's personal, and it requires a proactive plan. In the next few minutes, I'll break down the essential screening recommendations that you need to stay ahead of the game. Don't leave healthcare to chance. Know your options so you can stay proactive and catch cancer as soon as possible while it's still curable. I'm Cindy. I am a certified and licensed genetic counselor with over 10 years experience working primarily with women who have a higher risk for breast cancer. I spend every day one-on-one with patients, helping them understand what their options are for screenings when they're at higher risk. So what is a higher risk to begin with? 1 in 8 women get breast cancer. It is the most common type of cancer for women in general, but some women have a higher risk than that. Some women have over 20% lifetime chance for breast cancer. And these women do qualify to do extra breast screenings. Technically, the high-risk breast screenings are considered for women with risk over 20%. Now, keep in mind that a 20% risk, 30% risk, 40% risk is actually still in that woman's favor to not get breast cancer, but it is higher than average, so they should be more on top of watching things just in case it happens. Breast cancer is curable when it's caught at early stages. So for some women, we should watch them closer just in case so we could catch it early. Now, there are some women who have a higher risk than even that 20 to 30% risk group. Women who have problems in certain genes or who have had biopsies showing certain features that change the risk for breast cancer may have over 50% chance sometimes for breast cancer. And absolutely, that's on the more extreme level of high risk. But I will say it's not 100% risk for any of these women. And the screening recommendations are actually the same no matter how high that number goes, as long as it's over 20% lifetime chance. And in the last video, I did go over how you know if you're at a higher risk for breast cancer. So I will link that one at the end if you're interested in more information on how to learn that, to learn what your risk level is. In this video, let's talk about the screening recommendation if you do have this higher risk. Technically, all women should be aware of what their breasts normally feel like and look like. They call this breast self-awareness or breast self-exam. General recommendations are about once a month to check that tissue. And there's a lot of tricks to trying to remember this. You can either choose your birth date and on or about that date each month, check your breasts, or you could choose the first of the month on or about that date, check yourself. If you're not on that day, you don't have to give up. Just do it the next day. Just being aware of what things should feel and look like is important so that you know if anything's changing in between imaging technologies. Another thing you could do if you have a 20% risk for breast cancer or higher is have a clinician do an exam once or twice a year. This is different from what we recommend for average risk women because they've really pulled back from suggesting that average risk women have a clinical breast exam at all. And for high risk women, we are recommending it up to 2 times a year. Now that can be, sometimes you have a generalist and a GYN. If you stagger those appointments, you can ask both of them to do a clinical breast exam. Some people have access to a high-risk breast clinic, and that is another place where that clinical breast exam can be done oftentimes. So getting it at least once a year, twice a year would be ideal. And just having a doctor make sure that they're not noticing anything obvious that's changing either. I will say I've taught genetics in medical schools. They don't always teach clinical breast exams to medical students anymore. So knowing how to do it yourself, if you have a physician who's new, you might actually have to teach your own doctor how to do this exam. And the more they practice it themselves, the better they'll get, the better you get, the more you practice it. But hopefully they will start doing it for more of their patients and not just you. So again, getting more experience there. Now let's get into some of the imaging recommendations. The first one is the annual mammogram, which is the same recommendation that we recommend for average risk women. The technology, yes, it's been around for a long time, but the technologies have improved drastically over the years. So I've seen misinformation out there that it's 120-year-old technology. Okay, the first mammograms were out there 120 years ago, and they weren't even looking at breast tissue on women. They were looking at mastectomy tissues after surgery. So yes, that's been around there a long time. Mammograms have been fairly routine as far as recommendation for screening breast tissue since about the 70s. Really not as long as the technology's actually been available. That has been a more and more standard recommendation for doing every year, even for average risk women. Now, for women at 20% risk for breast cancer or higher, then we may recommend screening earlier, starting at 30 instead of at 40, or some average risk guidelines say 50 for screening, and absolutely doing it every year, not every other year. And the idea there is if you are at higher risk, you may also have a higher risk at a slightly earlier age than average. And we want to make sure we're catching things as early as possible. Now, there are limitations to mammograms because, yes, it's very density dependent, and younger women do tend to have more dense tissue than women after menopause. However, mammograms still pick up the majority of breast cancers, even in women with more dense tissue. Not as high of a detection rate as you would see in women with less dense tissue, but it still does pick it up, and usually at earlier stages. And mammogram is actually the best technology to pick up what they consider either stage 0 breast cancer, or some people do call it pre-cancer, ductal carcinoma in situ, depending on who you talk to. Those cancers are stage 0, often picked up by looking at calcifications. They don't always show masses, and mammogram is actually the best technology to pick up calcifications that are changing in the breast tissue. Now, you may have calcifications that you see noted on your mammogram reports. If they say they look benign, then I'm not worried about it. Many breasts have calcifications in them, but if they're changing or look a little different than the typical ones, that's when they start flagging it, start saying, should we double check this further? They're also looking for masses, and the idea there is a breast mass will show up more dense than the background typically. If the background tissue is pretty darn dense, it may make it a little bit harder to see. And that's also why they're checking year to year to see if there's changes in how it looks. That is also important. If you're changing locations, you want to make sure that you release the images from the previous location you were at to the new place you're doing your mammograms so that they can compare the images from your prior exams. There's a second breast screening that we also recommend to women who have a higher risk for breast cancer, and that is a breast MRI. And breast MRIs are really a completely different technology. MRIs have no radiation with them. Mammograms have a slight amount, about equivalent to your standard x-rays, but breast MRIs don't have any radiation. They are a longer exam, and they do need a contrast dye that helps them look for the breast cancers. That dye actually gets absorbed faster into breast cancers because, well, breast cancers attract blood vessels to themselves so that they can feed themselves. So they tend to light up faster on a breast MRI than the background tissue. They can also watch the washout from this dye as well to look for any signs of anything concerning there. Now, breast MRIs usually take a longer period of time. The standard breast MRI can take 30 to 45 minutes to do that full exam, to get the images prior to the contrast, do the contrast and watch it wash out. It is also in that small tube. Oftentimes you're going in feet first for breast MRIs with your hands over your head on your stomach. That is because breast tissue tends to flatten out when you're on your back. So if we are laying on our stomachs, they have a special table set up, not the most comfortable thing, but it helps them image the breast tissue better. Now, there are some new technologies with both of these types of imaging. For the mammogram, there is a standard digital 2D mammogram, but there's also 3D mammograms, which help by taking a few extra angles of imaging to see through denser tissue. So if you are younger, premenopausal, have more dense tissue, you might want to ask for the 3D mammogram. Also, with a breast MRI, there's a newer second option that is not available everywhere yet, but is becoming available in more and more places. And they often call it either rapid breast MRI or fast breast MRI or abbreviated breast MRI. It is a much shorter exam than the standard breast MRI. It's about 10-15 minutes. For people who have trouble laying down with the arms up above their head, that may help them with the comfort. If you get claustrophobic, it's not as long in the exam itself, so that may help you as well. The detection rates with rapid MRIs do seem pretty similar to the standard extended breast MRIs. It is an extra option. The other reason why some people pursue that route is if their institution offers a cash option for that test, it is sometimes cheaper than the deductible is for a patient, especially if they have a high deductible plan for a standard breast MRI. So if you do have a large potential cash out of pocket because of your insurance plan, in the US this is an issue, then the rapid or fast breast MRI might be actually cheaper than your deductible would be for a standard one. And by the way, breast MRIs do pick up some things a mammogram can miss, and vice versa. So breast MRIs often will pick up, say, stage 1 to 2 breast cancers better than a mammogram would. The mammogram can pick up the stage 0 DCIS better than a breast MRI can. So when we put these two exams together, they do increase the overall detection rates for people and at early stages. The other advantage there is, well, you can stagger these. You don't have to. Some people will do them close together in time, and the advantage there is, well, each screen can flag benign things as well. And if you're doing those screens kind of back to back, you might get a comparison between them. You might clear some of the potential callbacks. If, say, one of them they're questioning things on, and the other ones that, no, that looks really benign. The other option is to stagger those imagings through the year. So one is done at one point in the year and the other one is done about 6 months later. That gives more frequent checks so that you are being watched and imaged every 6 months instead of every year. And again, if our whole goal here is to catch things as early as possible, if they are to happen, then screening every 6 months does help us do that. You add in those clinical breast exams in between the imaging, you add in your self exams. If anything comes up between any imaging, get it checked out. They might suggest extra imaging, but in general, that gives multiple times during the year where things are being checked. Because with breast cancer, early detection means a treatable cancer. Now, sometimes we do make adjustments to these recommendations, so you may want to check with your provider or ask for a referral to a genetic counselor or a high-risk breast center in your area to tailor this to what you have for your family or your personal risk factors. There are some genes where the average age of detection of breast cancers is still later, so we might actually suggest extra breast screening, but we might not start as early. On the flip side of that, if there is a breast cancer diagnosed at a younger age in the family, we may adjust that starting point, usually around 5 to 10 years prior to the earliest diagnosis in the family, so that we can make sure if it is to happen, we catch it. So there are some personalization that we can apply to these recommendations. It's definitely good to check with your provider to see what you should be doing specifically in regards to that. But at the minimum, you should at least see a provider who can do a risk assessment for you and let you know what you should be doing. And another tip for when you're talking to your providers, you may actually have to send them reminders for when you need these referrals. This comes up even more frequently for breast MRIs because it's not a standard screening for all women. Don't feel like you're nagging, but you may have to ask your provider and remind them that you're at higher risk for breast cancer and you need these referrals so that you could get your screenings. You may also have to ask for a referral to a genetic counselor or a high-risk breast clinic so that you can stay on top of this. And that is probably the most ideal scenario, especially the high-risk breast clinic, because they're often set up to do those clinical exams and set you up for those extra breast MRIs and mammograms earlier than typical. Most genetic counselors can run these risk assessments and make those recommendations so that it's in your file for your doctor to be aware of, but many genetic counseling systems are not really set up to see patients every year to help them with that process. So that's where either a provider needs to do that or a high-risk center would need to do that. However, if you would like a referral to a genetic counselor, if you don't know of anyone in your area, there is a great resource provided by the National Society of Genetic Counselors on their webpage, and it's actually really easy to remember. findageneticcounselor.com. So I hope this information helps you get you what you need, help you make the arguments for what you need. I will be providing additional resources on breast cancer risk, how do you know you're at higher risk, and some of the genetic factors in the future. And then we'll get into some other cancers in the same topics. If this is of interest to you, I do have a playlist for breast cancer risks and what you should do about it. I will link here at the end. I also have a newsletter where I send out additional tips and tricks and updates as they become available. And if you'd like that, it's completely free. I will put the link in the description below and in a pinned comment. If you have any questions or concerns about these imaging recommendations, how to know if you're at higher risk for breast cancer, please feel free to leave a comment below and I will try to get as many answers out there to you as possible. And subscribe to the channel to get updates on future videos. And we'll see you with our next one. Take care.